Patrick and I, together with Chinchettrow in computing, have been doing with London Borough of Islington. And this is part of the London Met Lab Empowering London work, as we're as challenge champions for poverty and deprivation. So we've been working with Islington on this. And basically Islington wanted to look at the unemployment amongst Black, Asian and minority ethnic communities in Islington. But one of the problems is that it always is this umbrella term of Black, Asian and minority ethnic communities. And they wanted to go sort of deeper into that and look at the specific communities, the specific minority ethnic communities within Islington, which are suffering from the highest levels of unemployment and which are least able to access the employment support services which are available. So as part of this, Cheng did a quantitative analysis and Patrick and I did what was called the qualitative analysis, which actually involved 6 focus groups with the ethnic minority communities which were most affected by unemployment, high unemployment in the borough. So this was with the communities which came out as highest were African communities, Black community in general, the Bangladeshi community and also the Turkish community, which perhaps we'll come back to because that came up in a later bit of data analysis. So we did these 6 focus groups with the Somali community, with the Algerian community, with Bangladeshi men and a separate one for Bangladeshi women, one for Pakistani community and one for Afro-Caribbean community. And basically one of the key focuses of the focus groups was to ask people what barriers they were experiencing in terms of accessing jobs. And this is where health comes in, because perhaps the single most significant barrier across most of those groups was health. And health emerged as a really strikingly key feature for all of the groups, but especially for some of the groups, particularly for Bangladeshi men and Bangladeshi women and Algerian men in those focus groups that we did. And this was a range of both physical and mental health problems. Perhaps particularly with respect to physical health, issues that were key were diabetes, but also severe levels of back pain and mobility problems. And what was really sort of notable here was that the health problems and the serious chronic health conditions that particularly older and particularly again Bangladeshi and Algerian unemployed people were experiencing had been caused by their previous jobs. So it was previous jobs where they'd worked overwhelmingly in low-paid manual jobs, particularly for the men in the restaurant trade, in catering, hospitality, and for the women, all of the Bangladeshi women that we spoke to in the focus group worked in social care. And all of those people who had chronic health conditions had them as a result of their employment, yet none of them had ever received any compensation. They basically just been got rid of, and there were no understanding of employment rights or compensation at all. But in particular, their chronic health conditions were now the major barrier that they faced, or one of the major barriers, along with other barriers to do with sort of age and language and digital illiteracy. But health was perhaps the key barrier that they faced in accessing work. So in terms of recommendations, the recommendations around health are absolutely key from the project. And it wasn't just physical health, but also mental health. Mental health came out as an absolutely, again, perhaps not surprisingly, key issue. Again, perhaps particularly amongst the older people involved in, but not just, but especially highly amongst the older people involved in the focus groups, and again, particularly in the Bangladeshi and the Algerian focus groups. And particularly amongst men, although having said that, we also did a focus group with what were the sort of 12 biggest employment service support providers in Islington. And a number of those worked particularly with Black, Asian and minority ethnic women and talked about the increasing levels of mental health problems amongst unemployed Black, Asian and minority ethnic women, particularly in respect to anxiety and depression. And one of the things that came out of this sort of stakeholder focus group was the need to normalise mental health, and the need, particularly the issue was brought up in the stakeholder focus group about young Black men for whom mental health can often be seen as a taboo amongst the groups that they were working with. And one of the strongest recommendations to come out was the need for employment support services to be holistic and to also include mental and physical health support, and particularly signposting. But actually those services, such as one called Hillside Club, that provided a holistic service, were sort of seen to be a particularly good role model. One of the other things that came out was that COVID was very much had very much impacted on people's health, and particular unemployed people's mental health. Particularly, again, this came out with respect to men, particularly Bangladeshi and Algerian older men, and that was particularly in terms of them losing their jobs, often during COVID, as a result of working in the hospitality restaurant sector, for example, and the impact that had in terms of their own identity as breadwinner within a sort of more traditional family, because these were mainly older men that we were talking to, and particularly the isolation that they felt about being at home, and there was a lot of reference to mental health problems from all of those groups, but as I say, particularly the Bangladeshi and the Algerian men that we talked to. These were just a couple. Obviously, we used quite a lot of quotes to highlight some of the key points that were coming out. So these were a couple of quotes that we just highlighted for today. One was from a Bangladeshi man who said, "I think that the generation we're talking about," and again, this is men in their 40s and 50s, like are the ignored generation. Employment will give people two things: one, that they'll get employment, and the other, that they'll get back their self-respect. And then from an Afro-Caribbean woman in one of the other focus groups with Afro-Caribbean community said, "I'm a tough person, but when you've been made redundant, it does knock your confidence. And when you've been unemployed for such a long time, it's a very lonely place. You've got people around you and family around you, but it's you that's unemployed. So it can be lonely. It can be a depressing place, especially if you're looking for a job and you're getting knocked back, knocked back, knocked back." So this reference to the impact of COVID, the impact of unemployment on mental health, was a very common theme that ran throughout the focus groups. And again, particularly the impact of COVID making that worse. One last point I'd like to make before I pass over to Patrick is the issue about the job centre, because pretty much the only employment support service that people knew about was the job centre, and almost entirely people's experiences of the job centre have been negative, and especially people with health conditions and chronic health conditions and health problems. For them, they had enormous mistrust and fear about using services in general, and that came largely from their experience of using the job centre. They saw it very much, and their experience had been one where they had just experienced sanctions, where they were very, very fearful of losing their benefits. And in fact, some of the people that we spoke to in the focus group had actually lost their benefits as a result of being sanctioned through the job centre. And in particular, through being offered unsuitable work due to their health conditions and their chronic health conditions not being respected through the job centre service. So there was a lot of fear and mistrust about using the job centre, and that actually then went over to a general fear and mistrust of using any official services, including the council. So I put another couple of quotes there that you can read. You know, in the job centre, they force you to go for things that you know you'll not achieve. And then, when I was initially made redundant and then sick, I thought they'd help you to find a job, but I didn't find it so helpful. And then finally, I'll just read this slide and then I'll pass over to Patrick. And again, this was from the Bangladeshi men focus group. This generation that came to this country, they came for jobs, factory jobs. Those in their 40s and 50s lost their jobs, and there's no chance nowadays. These people did a lot of physical work, and as a result, they're suffering and they're not fit for work. But the job centres after them, asking them, do that, do this. 100 times they're chasing them. It's a great problem. So this was, again, perhaps it gives us the sense of fear and mistrust that people with chronic health conditions had in their dealings with the job centre on a day-to-day basis. Okay, thanks. I'm just going to pass over to Patrick now to carry on. Thanks.
Thank you, Jane. I'm going to move on to some of the key findings we got from the research, particularly from the focus groups. One was that when we started out, it was kind of about ethnicity and about the way that BAME communities can access jobs. But once we started digging down in the focus groups, we found out it's much more complicated. I think is kind of intersectional issues. In other words, you can't separate out people's life experiences and then say it's one thing or the other. For older people, there was an issue about language, particularly for Bangladeshi people, for example. But for younger people, clearly it wasn't. And when I did a focus group with Somali people, the younger people were all at university. They're all finishing off their degrees, and their experience and what their skills are and what they want to do is very different from the older people in the group. And it may feel a slightly uncomfortable scenario in the sense that I had a group which is completely different people. And for the younger people, to say for the younger people, they said, yeah, we can get a job. We just can't get a job, the sorts of high-paid jobs which other people get. So clearly, and it's explicitly around racism, they felt that race was an ethnicity was an important factor in whether they get the jobs they wanted. Physical health, a lot of people be carried out poorly paid manual jobs. And what was interesting was that for the Bangladeshi group, for the men, Jane did the focus group, but I did the transcription, so I never met the group. And when I transcribed it, I listened to it and typed it out, and I thought they were probably in their late 60s and early 70s, the people in the group, the way they were talking about their health. And actually, they were kind of 40 to 50. I was really amazed when I found out what their ages. And again, they're hounding by the job centre. Came out really strongly across a lot of groups, and a sense of severe impact on self-esteem, particularly in communities where men's job is to go out and be the breadwinner and to bring home money. They perceived that as their role, and they ended up either not having a job at all and kind of being at home and feeling they've lost their role with their sitting around their grandchildren, which they thought was a great burden. They didn't want to be sitting around their grandchildren, they wanted to be out. And also a lot of them were taking Uber type jobs, well, literally Uber jobs. It's a lot of people moving into taxiing, and that's an area where wages are falling as well, conditions are falling, food preparation and informal childcare. Interestingly, when we talked to them in depth, and I was talking to some of the people in the group, and I was saying, well, what about going for a higher paid job, a manager? And that wasn't on the agenda. What they just wanted a job, for the older people. For the younger people, they were looking in kind of aspirational way at different sorts of jobs. Really important finding was that a mistrust of official organisations, and that's an important lesson, I think, in this, is that their experience at the job centre in particular was that they were hounded, and that kind of fed over and swept over into other organisations. So they wouldn't think of going to the council because they thought if they went to the council and iWorks and their employment service, they'd get treated the same. And interestingly, when we talked to them about how they ended up at iWorks, which is a council employment service, they just stumbled across it. They hadn't planned to go there. It's just a friend had mentioned a phone number, or they went into the office and someone talked to them. So in terms of the future, which we'll go on to, the kind of recommendations, that's quite key. In terms of their health and their work, there's a kind of a vicious cycle, really. Was that they couldn't get experience without a job, and they couldn't get a job without experience. So they ended up in quite poor quality jobs where their health suffered. And then it impacted on their mental and physical health. And because it impacted on their mental and physical health, it meant they couldn't go for the sorts of jobs they wanted to go for. And there's a lack of aspiration. So there's a number of different kind of vicious cycles in play here for these people. In terms of recommendations to Islington, the key one is that people will not come to Islington employment services. Either they don't know about it, or they're worried that it's going to affect their benefits, or they don't want to approach official organisations. So our main recommendation was that Islington go out to the community. They go out to the community centres, go out to individual communities. One of the problems is some of the communities are actually quite hard to engage or hard to hear because they haven't got that formal structure going on with community centres. The employment support should include help with mental health, for example. And there's plenty of services out there, but there's nothing linking the different services. Confidence building was important, a real lack of confidence in their own abilities. And what people talked about in the focus groups was the things they lacked. They had lots of experience, they had lots of skills, but they kept on talking about the skills they lacked rather than the skills they had. And it's also to go out to GPs and health centres to encourage people, to get employment support. Basically, the key message is people aren't going to come to Islington. They're just not, because either they don't know about it or they don't want to. So Islington, what they're going to do is take the employment service out to people so that it's more trusted and more engaged at a local level. In terms of health, that it came out, as Jane was saying, very, very strongly, is this: you can't look at employment without looking at health and what people's capabilities are and the impact of unemployment on their health. Okay, we'll finish up there because we've done our 15 minutes, I think. Thank you very much for listening. I was just wondering, is there any questions for myself or Jane?
Thank you, Patrick and Jane. The space for the question is after the presentation that it follows yours.
Oh, is it?
Yes.
Right. I realize that. Okay.
Yes, it's a session. So there will be time for questions at 3:10. I'm looking at the program.
Right,
yes.
Okay.
So our next presenter will be Raquel Chinchetru is a professor of doctorate in health psychology student. And I'm trying to upload her slides. Raquel, if you are getting ready with your mic, I'm trying to upload your slides now.
There's
Raquel, are you there?
Yes. Yes.
Okay. Brilliant.
Sorry.
Brilliant.
Hello, everyone, and good afternoon, and thank you for still being here. And thank you also for all the presenters. I found very fascinating research going on here. At the moment, I'm presenting a qualitative study that, as part of my doctorate in health psychology, in order to understand provider perceptions and experience in working with people who suffer chronic pain. That's a little bit of index of context of what I'd like to cover today. Is give us a little introduction about what is pain, as well as the epidemiology and background about the research, aims, methodology, as well as literature. So what is pain? According with the International Association for Study of Pain, pain is considering an unpleasant sensory and emotional experience associated with actual or potential tissue damage, or described in terms of such a damage. What I found very interesting of this definition, that actually has been updated recently, is historically pain has always been considered mainly an unpleasant sensorial experience, where now it is also an emotional experience. So pain is not just considered a physical sensation, but it's also considered an emotion. The inability to communicate verbally does not negate the possibility that an individual is experiencing pain. We can create, as a healthcare professionals, many scales to measure pain, but at the end of the day, pain is always a subjective experience. According with the definition, sometimes you might see cases of people who suffer chronic pain with no tissue damage, but the experience of pain is still there. So it's still considering a chronic pain experience. Just want to give you a little introduction about the difference between acute pain or chronic pain, especially for people who may be not familiar with this area. Acute pain is usually more a short-term condition that lasts for less than 3 months. Usually is linked with a tissue damage. It can be used as a protective device because pain, for an anthropological point of view, keeps us alive. It helps us to warn about threat, about danger, and it can respond very well to prescribed medication. Usually, acute pain can go better with the time or disappears over the time. However, chronic pain is not as adaptive as acute pain. It lasts for more than 3 months. Pain is no longer caused by new tissue damage. It can be unhelpful or misadaptive, as it can create a lot of misinterpreted signals that cause suffering and psychological problems such as depression, irritability, low mood, or anxiety. Medication is often increased, but it does not change the intensity of pain, and it tends to have many side effects. Pain remains, but it's not consistent. And in case some of you can see sometimes primary pain or secondary pain, usually, or we can read it as primary suffering or secondary suffering as well, is currently defined as primary pain as biological sensation, that it can be occurred by intrinsic or extrinsic stimulus and is unpredictable. However, secondary pain is the interpretation that the brain, or the perception that the brain does about that experience of pain. I always talk metaphorically, but I think that the brain sometimes can be like a picture camera, that what it tends to do is to zoom in the experience of pain. I also highlight the dimensions of chronic pain, in which healthcare providers usually work in all these dimensions, not just in the physiological aspect. So it can be the sensorial aspect, the space, the time, the intensity, the emotional aspect of the pain. So how makes the pain the person feel? Cognitive evolutional, that means the meaning and valuation of this experience and how can influence the memory process, especially in chronic pain, that has a big role. And as well, affective and motivational, so that look to the person's behaviors towards pain, as well as the coping mechanisms. The epidemiology, and I have to say this study was in 2016. There are new studies that are still not complete, especially in COVID, showing that there is an increase of chronic pain, specifically in neuropathic pain, but the studies are still not complete. However, I found this data from 2016 quite shocking, because affects 20 million of adults only in the UK, so affects 1/3 of the population. The epidemiology of chronic pain, usually chronic pain tends to increase with age, in particular after the 7th decade. However, while pain in the lower limb increase with age, in the areas of low back pain tends to decrease. Is also linked with early mortality, such as cancer or cardiovascular disease, with predisposing factors such as physical activity or unhealthy diet. There was a survey in the European survey saying that in 2006 that was affecting 19% of European population as well. Just put you some pictures to make it a little bit more fun, especially when we talk about pain. This is a picture about the first factory in opioids that was in India in 1993. And even if it looks a very old-fashioned picture, I think it still has very contemporary applications, as still many patients with chronic pain still rely on opioids and pharmaceutical companies, in spite the opioids in the long term cause severe side effects, and actually they don't work with chronic pain and symptoms as well in the long term. I'm going to give you a little introduction about that. According with the British Pain Society, pain is the most common reason that people attend to the GP, so it's between 1 to 4 people. There is a worldwide problem with opioids consumption, especially morphine, codeine, tramadol, oxycodone, and fentanyl are some of the most common and powerful painkillers medicines available. However, opioids are prescribed too frequently for other common conditions such as low back pain, arthritis, neuropathic pain, and there is no evidence of efficacy, especially after 3 months. On the contrary, there is a good evidence that suggests that there is a potential harm for substantial side effects. It tends to be increasing in medication, and the experience of pain is still there. So one of the things that Public Health of England, especially in 2019, are trying to work is develop more interventions by healthcare providers that can work with the biopsychosocial model and give them alternative treatments as well to medication. The background of my research is actually working in pain clinics management programs that are based in the biopsychosocial approach. So in other words, healthcare professionals They're applying the biopsychosocial approach to promote relatively positive changes in these three areas, biopsychological as well as social. Chronic pain is a long-term condition that requires to be manageable using these three areas, but also in order to optimize a positive patient-provider interaction, it is essential that good communication can arise, as well because usually patients who have chronic pain develop long-term healthcare relationships with the healthcare providers. There is a limited research, and that's why one of the reasons of why I want to do this research in the field of communication and chronic pain, and also how this interaction can be optimized for better interventions for the patient, but as well for the satisfaction of the healthcare provider. In this study, patients have reported battle metaphors to express their interactions with the providers, as well as doctors have referred working with chronic pain patients as thankless job. There is outcomes that can create an adverse effect in the process of patient-provider interaction and communication. And these intervention outcomes, as well as the patient satisfaction with the whole service. According with the model of patient-centered care, it is important to demonstrate in this interaction, demonstrate empathy, empowering patients, and treating patients as partners in their health care. All of these are very important components that can contribute to create a good level of patient satisfaction, as well as decreasing rotation of physicians that work with chronic pain. Providing a good patient-provider communication tend to lead to less chance of the patient continue searching for a medical diagnosis in order to explain the cause of the condition or find the source of the condition. And this is very relevant for the management of chronic pain, as there are many conditions from central sensitization where they cannot find a single cause, and the patient struggle a lot to actually accept it and trying to move into more self-management or coping strategies to manage the condition. These interactions can affect patient satisfaction as well as the healthcare provider's professional delivery. In spite of the healthcare professionals reporting that working with chronic pain can be frustrating as well as challenging, very little is known about what is the experience by the healthcare provider. Promoting well-being as well as professional standards are very relevant, as well as developing an empathic communication skills with the healthcare provider can bring more outcomes, not only for the interventions, but also for the satisfaction of the healthcare professional. It is recognized the relationship between patient and providers is essential in order to achieve the best outcomes. However, very little is known in the specific field of chronic pain. There was one qualitative research actually in the States, 2010, that was exploring provider perceptions in working with chronic pain. These findings actually very interesting. The findings suggest that the patient-provider relationship were important in providing a good general quality service. Providers perceive a number of barriers while working with patients with chronic pain, including beliefs about pressures for patients to treat with opioids medication. That's why I did give a little introduction about the opioids burden out there in people with chronic pain. Credibility of patients, beliefs, description of their own condition, and also the comorbidity of having chronic pain, such as problems with decreasing social activity, depression, anxiety. Providers also experience negative emotions in the provision of this care, such as frustration and guilt. My research at the moment is needed to understand the perceptions and experience in working with chronic pain here in the UK. The focus of this study is to examine the perceptions, but also the experience in actually working with them. The research has implications not only for improve better outcomes of the intervention, but also in order to improve quality service, as well as understanding which are the providing needs and the difficulties they might face in working with chronic pain, and how also there can be support with clinicians' interpretations and also with feelings of burnout as well as negative emotions. The method of this research is a qualitative study using cross-sectional and semi-structured interview design. The study will take place in a community-based pain management clinic that has commissioned by local clinic commissioners group working in partnership with the NHS. The main interviews will be delivering qualitative interviews with physiotherapists as well as psychologists that working in these services, providing interventions with chronic pain, and they also are part of a multidisciplinary team. The ethical considerations for me to carry out this research was find potential participants that they're going to be invited by sending a general email to the company. The interview and the interviewer, they don't have a pre-existing relationship. And also the participants are reminded at all the time that they can withdraw of any time of the research, especially if they feel very stressed, will be able to access and apply the London Metropolitan University Distress Protocol. There is some sample criteria, inclusion criteria and exclusion criteria. So the main inclusion criteria is working with physiotherapists and psychologists. So they work more from the physical aspect and psychological aspect in the provision of working with chronic pain. The exclusion criteria will be those that haven't passed the probation period yet, and also includes the team that I don't work directly with. The samples, as I say, are pain clinics. They work in partnership with the NHS. All the participants are working from the same organization, delivering physical and psychological interventions, and they've been passing more than 6 months the probation period. The materials at the moment I'm using to work with this, to analyze this research is I create a consent form when the participants are willing to be part of this research. They have to sign a consent form. I also send them an information sheet in which I cover all the information about the project, my contact details, and also why they have been invited, and they can remove at any time. I record the interviews with MP recorder in order for me to do transcripts, verbatim transcripts of these interviews. And I also send them the interview schedule before the interview for them to have a guidance of the main questions that I'm going to be addressed. One of the aims for me to cover the design, the interview, is also avoiding in asking them too many research questions or technical or professional language, avoiding questions that involves a preferred answer or promote a judgment, and trying to use open questions in opposite to closed ones, and inquiry about a specific experience in opposite to abstract ones. The procedure is I send through my manager a general invitation to be part of the research, because this company is national. I particularly work in South, so I'm trying to recruit people from North. And then the participants that they are recruited, they can sign the consent form. And they are all the time to remind that they can withdraw the research if they need it. And then I establish a meeting time, whether it's over the phone or also by Zoom, to deliver the interviews. And I always try to create breaks during the interview for them if they need it, to rethink or reflect more on a particular question, or if they need more time.
Sorry, Raquel, there's 1 more minute left.
Oh, okay. The data, I finished now. The data analysis I use in IPA. I try to use a 1-hour frame in order to not overwhelm clients. And the reason why I use IPA is because it identifies essential qualities to make someone live experience. Thank you very much, nearly there. Thank you for letting me know, and thank you for all.
Just in time. Brilliant.
Just time, yeah,
Yes.
no, I was there.
Brilliant. Thank you very much, Raquel.
You're welcome.
And
thank you,
Jane and Patrick. So now we can go through, open the floor for questions. I will start with the first questions. I think that Patrick has been, but probably you would like to comment here. So it was Shabna wanted to just add that the Asian BMA communities of elderly who have lost jobs in the pandemic were put to pressure to apply for universal credit, which require logging online and its skills. This is very difficult for some of the people who lack in skills such as computer use or emails and so on. Patrick, I know you said something, but Jane or Patrick, if you like to come in.
Perhaps if Jane answers this, because you've got a wider perspective on it, and I'll add anything in.
Okay, thanks, Patrick. Yeah, I was just agreeing with Shabna. I know she's got to go and pick children up, I think, but one of the, obviously we focused here on the health issues and mental and physical health conditions, but aside from that, in terms of barriers, Shabna's absolutely right that one of the key barriers, particularly for older Bangladeshi and Algerian people that we interviewed, was lack of digital literacy. And obviously, as she says, this is especially acute in the current context where everything's gone online. So, and it's particularly intense when people lack English language skills as well, because if you go online to navigate anything online, as we know, if it's not in your language, it's impossible. And Shabna says about sort of universal credit applications being online, everything's online. So it's really impossible. And I think the sense that came out was a sense of being really excluded from everything increasingly. But again, particularly older. And I'll pick up that point Patrick made. When we're saying older, we're talking about people in their 40s and 50s, not people in their 60s and 70s and beyond. We're talking about a generation in their 40s and 50s who are lacking in digital literary skills, as well often as language skills. And so our key recommendations were really about placing digital literacy and language skills training in community organisations. Yeah, I'll come back with anything else.
I think that, thank you, Jane. I think that Shabna is back. Shabna, would you like to pop your mic in?
Yes, thank you.
Yeah.
Thank you, Yolanda. To add to that, yeah, thank you, Jane. That was very useful. And I know through my experience, my own experience, as well as interpreting for Bengal Bangladeshi families, I've come across a lot of difficulty and challenging. Obviously, language is one of the barriers that they're not able to seek work. Because they can't speak the language, so they can't get well-paid job, only the carer's job. But even that, sometimes I find that some of the housewives who's always had work, been at home looking after the children and family, and now suddenly, because they're claiming universal credit, both husband and wife, both of them have to sign on. They have to show that they're actively seeking work. Now, these women have never worked in their life, remember that, and they don't have the skills or language or any English courses that they've attended. They've always been a housewife. So I've come across few in my experience that they're under pressure to actually attend ESOL courses, which they are doing. But the fact that the impact of that, they're mentally drained and they're exhausting because they're health-wise, they're not well. Some people are not. Some, they feel that, they can't compete with the rest of the community where they're going in to sign or even go to the English classes, because there are younger people, generation who are competing with them. So for them to apply for a job such as cleaning in a school, there's 80 applications and they're one of them. Now, they wouldn't take somebody who's never worked in their life, who's been a housewife, compared to somebody who's just 30 and who's only have one child and who's able to speak more English. So that's all I just wanted to add. Sorry, there are lots of challenging in those areas.
Absolutely.
Can I just add something? It's a really interesting point, Shabna, is that there's something, you touched on something which came out of the research as well, is that the people we talked to, generally the women were looking for work which would allow them to, work within school hours. and they wanted one or two, maybe more than one job actually, but as long as they could access it during school hours, and that was another potential barrier. But interestingly, none of them really talked about childcare. The assumption was, I've just got to get a job during school hours. Nobody had sought out any particular childcare to help them to get into work or anything like that. So it's really interesting, and I think you're absolutely right. The people we talk to, admittedly, remember it's focus groups, so it's only small groups of people, but that very much reflected what you said. But some people, the problem for some people was because the employers knew they didn't have any choice, they were mistreated. Because the employers knew they couldn't go anywhere else, they're not going to get another job. They just treated really badly with no health and safety. So it's a vicious cycle, really.
Thank you, Patrick. I think there is a comment as well from Shima, which you are welcome to pop your microphone on if you would like. Otherwise, I'm happy to read out. She says, in addition, some younger BMA adults, especially younger men, have a significant unemployment rate due to I suppose it's home and violence offences, or due to violence offences, young offenders. Okay, come in.
Shima. Yes,
Shima,
what I was talking about, some young men, especially young, when they were at school, obviously, they didn't do well in their education, and they had other crime, and they did crime. So therefore, when they grow up, when they're adult, it affects them. It stops them from getting a job because they didn't do well in their school, and they had crime and violence history. So that's those are the things that stops some young men from getting into job.
Can I take that? Is that okay, Jane?
Yeah.
Again, an interesting point. It's not one we covered during our research. It wasn't something we covered in the focus groups. And clearly, irrespective of ethnicity, is that if you've got a criminal record, it's not going to be great for you. And if you don't have qualifications, it's going to not play well for you in terms of job market. But you need, if you look at the wider statistics about education, particularly in London, is that ethnic minority groups, younger people, achieve very well, and in fact, in looking at GCSE results, achieve better than white communities in terms of qualifications, but the unemployment rates are still higher. So there's something else playing in here. It's not an individual thing about behaviours or you don't know certain things. It's kind of about broader structural issues, I think, about exclusion from certain jobs markets. So you have to be quite careful about looking at individuals, and we're looking really at more structural reasons going on.
Can I just say something quickly on that? Because I think that certainly from the sort of people whose services that were working with young unemployed people, one of the things that they talked about was the experience of racism from school and other experiences, which shaped people's aspirations as well. And so a lot of people the people who do actually go to employment support services often go with very low aspiration, and that's because of what sort of their experiences that been shaped in the past, and experiences of racism is key there. And can I just quickly go back to Shapna's point about, I think there was a lot of focus on perhaps particularly South Asian women in their 40s returning to work, or not returning to work, sorry, looking for work in their 40s with, as Shapna said, no previous employment experience. And so that really is a group that needs to be, whose needs need to be focused on in terms of experience, because they have a complete lack maybe of employment experience. Anyway, thanks.
Okay, I think Verona, you have your hands up.
Yes, hello. It's very interesting the presentation, and I'm not sure who mentioned it about the childcare issue. Everyone knows I've worked with children and families for a very long time, and in one of the boroughs I worked in, Haringey, I saw the exact same issue among the Latin American community. Especially with my young women. So, and some of them in their 40s. And one of the biggest issues is if they are on benefits, they get the free 15 hours. So obviously they have to go to work, but they can't find work within that 15 hours, 2 hours, 3 hours. And most of them are forced by the job centres to go and do cleaning jobs. But the problem is with the cleaning jobs is they don't speak enough English, so they can't get the jobs. And if they don't get the jobs, their benefits are being cut. So I see the same problems, and I don't know what that is, but more research needs to be done, I think, with the whole issue around the childcare. And the work issue among the BAME community.
Thank you, Verena. I don't know if Patrick or Jane would you like to comment on that, or yes.
Well, just to support what you've said, really, Verena. I mean, it's absolutely key. It's interesting because most of the women, I'm thinking in various of the groups, were only looking for work within school hours. And so that very much focused them on looking for school meals attendant jobs, breakfast clubs sometimes, those sorts of jobs. You mentioned cleaning as well. But no one mentioned the possibility, even the possibility of childcare. It was almost, as Patrick said, it wasn't even sort of on their agenda. So it was very much about sort of, so in terms of services and recommendations, obviously that's an absolutely key issue for service providers to look into.
I think just coming in.
Can I just quickly add on that, what you're saying there, Jane, with the offering of childcare? When I have challenged some of the key workers that are supporting the women around childcare, and I said, look, they just can't do it in the hours that you're asking them to do, especially if there's half term. Who's going to look after children during half term, during the holidays? What about early mornings? Because everything is usually about getting to work at 7. And what they all said is that they can pay for it themselves. I goes, so if they're single parent, how are they supposed to, pick up their child? And who's going to look after them, especially during the half term? It's a huge issue because they expect them to pay for it themselves.
It's so unrealistic.
Can I just add to the comments more broadly, because I have one question as well for Raquel. But I think that what we're seeing, I will say across the conference, is that all these things that need a bit more of research to digging in, and I think that is qualitative research, the one that can, as Jane was saying, come to light all those reasons, all those motivations, all those social context or environmental factors that sometimes in a quantitative type of studies it get lost. We can have correlation, but we don't know exactly why people are behaving in the way they are behaving, or the contextual factors. And I think research of this type, like Patrick, for example, this is the session we're discussing now, and Jane, are bringing to the table a lot of factors that, even if the connections are very difficult to unpack or address in one intervention, but at least it's offering a much richer account of the reasons why people find it difficult or challenging to get into jobs. And my question in that introduction, but my question to Raquel in this sense, which is also trying to address issues of professionals dealing with people with pain, which is something that also in the first presentation was part of the problem, chronic pain, from the perspective of professionals. My question to Raquel is why, if you can explain a bit more, what is adding in terms of qualitative research, if you would like to explain a bit more what you have chosen, the interpretative phenomenological analysis, to look at this particular issue.
Thank you for your question. I mean, as you well explained, for me, it's very important not to understand the interaction between the healthcare provider as well as the patient, is to actually understand what is the experience underneath that. Not just in order to create better interventions for chronic pain, but also in order to look after the people who work with chronic pain, because it used to seem there is a lot of rotation of work, for people who work with chronic pain, trying to get different jobs after 3 or 4 years. So it's also to understand, and that's why I choose qualitative, to understand the qualitative sense of someone's experience while working with chronic pain. I think qualitative data can provide a much more deep way of understanding, as well as the emotional impact of working with chronic pain, that you might not see it in quantitative. And that's the reason why I use IPA. And also it's because I didn't see much research on communication in the process of working with chronic pain, and qualitative research. It's another thing that's why I think adding these studies can contribute to better interventions, but also to protect more professionals and understanding also the suffering of the professional in order to provide this intervention.
Thank you, Raquel. Yes, that's very, very clear point, especially if this a type of work that is very explorative. I mean, you said very clearly in your review of the literature that there are not many works being conducted on this, the professionals. So I think it's very interesting. Once again, bringing this particular approach, drawing on the experiences and the live experiences of professionals to unpack an effect that you mentioned, or an outcome, which is burnout, to help us explain that high rotation of vacancies. That's very interesting.
It's also the high level of turnover, people turnover working with chronic pain. I mean, I still collecting my data. I need 2 more people to complete my data. But for example, my last participant, she was leaving working with chronic pain in order to work in a long-term COVID clinic. And one of the reasons was because she was quite overwhelmed emotionally as well in working with chronic pain. So I think we have a lot of research about the patient-provider relationship, but not much specifically with these providers working with pain. That's why I thought it's important to highlight this research. It's also my field of work, so that's why I also experiencing that personally, So that's why it's important for me to see how we can draw better intervention plans, not only for the patients, but also for the clinicians who work with chronic pain.
Brilliant. Thank you very much.
You're welcome. Thank you.
I think, Shabna, you have your hands up. Would you like to come in?
Yes, it's a question for Raquel about the pain research that she's doing. So that was a very good presentation. Thank you so much. It was interesting because I come across when I'm interpreting for some of the clients in that pain clinic. And I find that a lot of the Bangladeshi community lacking awareness and knowledge of the actual topic itself on pain clinic. And when I'm trying to define to them, to explain what it is, they're describing their symptoms on a daily basis, and these women who are who's never worked in their life, and they're actually now all the children have grown up, and now this pain is consistently there all the time, and they can't describe or actually explain why this is happening because of the traumatic experience they've had looking after the children and bringing up the family. And then this woman particularly is a widow, doesn't have a husband, and she was dependent on her husband. And now she has grandchildren. So now it's a time where she shouldn't be experiencing traumatic pain or severe pain, because she's actually now in a better position to look after herself. Because whereas before in the past she was looking after her children on her own, no support from husband because he passed away. And she said to me one incident that, because obviously when I was interpreting, she was describing what incidents led to this pain. And she said in the snow, she was going to drop the kids and she fell over once on the snow and actually hurt her knee. And over the years, this is 30 odd years later, she's actually suffering from that experience, from that traumatic incident. So I felt for her when I was interpreting, and I was thinking, oh my gosh, now she doesn't have to do any physical aspect of the work. So I can see there are lack of, and sometimes these women, they feel stereotyped because they're on universal credit, but then the benefit is again chasing them like a vicious circle to say they're using this chronic pain to say they can't go out to work, but actually they're genuine. You know, the clinicians are trying to help them. So yeah, this is really good what you're doing.
Thank you so much. Yeah, I mean, I think as you say, pain is a very complex experience that is also can be modulated by culture, gender, age, and have different beliefs about the experience of pain. Yeah, and also I did mention in my talk about sometimes what creates difficulty in this relationship between the provider and the patient is actually the patient is still searching for the cause in order to sometimes searching for getting rid of the pain. Well, and that sometimes can difficult to provide a biopsychosocial intervention where helps the patient to develop coping mechanisms to teach the patient to manage the pain rather than get rid of that. And sometimes it requires a lot of explanation from a multidisciplinary team, not just from psychologists or physiotherapists, for them to understand that it's a chronic condition that might not go away, but it is also possible to manage. And your role in being an interpreter, I think, is a very important aspect in this interaction of communication, where sometimes, as you say, can be someone else as well as part of the interaction, and how the three persons, the interpreter, the patient, and the provider, can create a good communication between the three of them to provide the best intervention. And this is a very important factor as well to take it into consideration. Thank you.
Thank you very much, all of you, the presenters once again, and the audience for being so interactive. I'm afraid we need to really cut this short. We already have run out of time. We are going to have a very short break now, just to grab a cup of coffee or a tea, and around 3:30 we are back for the last session, so please stay with us, and thank you.
Thank you.
Okay, so sorry about that short break. It was meant to be 10 minutes, but we were very engaged in those conversations. So welcome to our session number 5 and the last one, which is entitled Educational Approaches. And our first speaker is Uzma Siddiqui, who is Senior Lecturer in Health and Social Care. Uzma, I'll leave it to you to introduce the topic, if you can hear me. Uzma?
Hello.
Hello. Okay.
Hi, can you hear me?
Yes, perfect.
Okay. Hi, hello everyone. It was really interesting to hear very engaging and really nice and informative presentations, especially for the past half an hour. It was quite interesting to hear about the different aspects of how the things are being done to support the community, and the very recent one which kind of identified how empathy and is necessary for engaging with patients who are suffering from chronic pain. So my topic for today is basically based on my research that was completed in last September, October, and it's based on my MALTHE project, which is a framework for embedding EI in the health and social care curriculum. So basically my research topic is on emotional intelligence and how we can relate to our service users and help our students to learn about emotional intelligence. So from the past, we have seen some skepticism with regards to people's engaging emotionally with different situations when it comes to health scenarios. But with the passage of time and with so many catastrophes happening in nowadays, I think it is the time to so that we can look into the fact that is emotional intelligence the way forward to understand health and well-being, and there are things that need to be changed. So people are hired for their intellect and their expertise, and they stay and they create their own niche with the help of their emotional intelligence. So what actually is emotional intelligence? So it is the adaptness to acknowledge, comprehend, appraise, and control one's own emotions as well as the emotions of others. And even groups. So it is allowed to people to handle added amounts of pressures, anxiety, and life stresses. So the purpose of my project was to look into and identify a framework of proposals to embed EI in the health and social care course curriculum by adopting an inclusive approach. So here is to identify and highlight the need to embed EI in the health and social care course curriculum. So through consistent evaluation and adjustment of courses in higher education programs, this can ensure they remain relevant and current with the constantly developing fields and professions. It's essential to reinvent the skills of today for their ever-evolving stakeholders. So who actually are the stakeholders? They are the teachers, the students, they are our immediate stakeholders, and then there is the overall university and its mission statement, and then comes our larger higher education authority and professional bodies and the QAA and even the wider society. So here is the pretext for my project. So in courses like, such as health and social care, the importance of EI cannot be emphasized enough, and the role it plays in personal and professional development of health and social care students and providers. It helps to train students to interact with and provide professional services to clients and patients, so to speak, the service users. There is a need for students to well equipped to deal with their own and service users' emotional needs, and to prepare them to manage a range of stressful and emotionally charged scenarios. This can be resolved with having a level of EI competencies mandated of them as future health and care professionals. So basically, my project was through a collaborative approach where students and lecturers, they were invited to for discussion and interview sessions, and both level 6 students and the fellow colleagues were involved, and their responses were collected, recorded, and included in the project. So in line with London Met principles of inclusive pedagogy and education for social justice policy, with a value-based approach of a curriculum, this pilot was designed to act as a catalyst or precursor for the redesign of the course to develop a framework with teachers and students in collaboration with the principal investigator. This was to introduce EI as part of the curriculum at all levels of the health and social care degree course, specifically and throughout all the degree level courses in the School of Social Professions in the future, as a recommendation. And as this was introduced basically as part of my NSM project with a pilot session, which was delivered to level 6 students on EI. And this was then developed on that. So there is evidence that students have been consulted and actively involved as to collaborate and work alongside in designing curricular resources and for different specialities. So there is emphasis on developing such curriculum design that are best suited considering the heterogeneity of the student population. So there is emphasis on developing such curriculum designs that are best suited considering the heterogeneity of the student population in relation to differing academic and professional domains, such as that of health and social care. So stakeholders' consultation and input should be considered before the inception or designing of any curriculum. So basically, this my research aims and objectives are based on the fact that I wanted to develop a framework through consultation with students and fellow colleagues for embedding EI into the curriculum in the BSc Health and Social Care course. And the main objectives of my project were to identify and drawing on published examples and sources of EI embedded in SSP, School of Social Professions, Social Sciences and Professions, and or related courses and degree programs in higher education to be used as support to build upon the EI proposals framework. So to do this, I adopted a collaborative approach to developing key proposals for embedding EI through interviews and or questionnaire responses of health and social care and the wider school colleagues and students. So another objective was to how can EI in health and social care be introduced at levels 4, 5, and 6, thus incorporating it in the overall health and social care curriculum through development of a framework for embedding EI into it based on inclusive pedagogies. And lastly, to develop approaches to introducing EI in the BSc Health and Social Care courses specifically and in the larger school in general at the LMU. So ethical considerations were sought in order to avoid conflict of interest. Students' work was marked anonymously to avoid any further biases. The students' participation participated in a semi-structured interview and or a discussion questionnaire, and they were randomly included through voluntary informed consent from all level 6 session groups. So the information gathered as the outcome of the interviews questionnaire with the fellow colleagues, lecturers, was kept anonymized to avoid any conflict of interest and bias. The ethical approval was obtained and sought via the MALTHE research ethics process through completing and submitting the university's official form. So the methodology adopted was to conduct a qualitative and interpretativist or constructed approach paradigm to primary research involving a selection of stakeholders. So the project was conducted based on one-to-one semi-structured interviews and or responses to a questionnaire via email. This approach was adopted as it allowed for interaction with participants to try to understand their viewpoint and their interpretation of the topic. So based on the project objectives and in consideration of the inclusion-exclusion criteria, the involved current students at level 6 who attended the leadership and management module in the professional context were included in the study project. So fellow colleagues teaching on the same module and the colleagues, fellows, academics within the School of Social Sciences and Professions from other related courses such as social work, youth work, childhood studies, and community work were involved in getting their perspective from a cognate field of practice. The project was conducted based on some one-to-one semi-structured interviews and or responses to questionnaires via the email. So here is the diagrammatic representation of how the EI was introduced within the framework of health and social care curriculum, and it was based and adapted from his instructional design model and Ouija board model. They were used to make a base of the research in order to introduce the EI strand into the health and social care curriculum, the instructional design approach was adopted to identify the range of key dimensions of the curriculum, combined with the Ouija board model to put it into practice as an overall process and to bring flexibility in the curriculum design. This was based on the diverse student learning requirements and the available resources. The students and the academic colleagues from the various disciplines, as has been said previously, were involved and were invited to contribute to the redesigning of the curriculum. So here are some result findings from my my research project, and they are based on the questionnaires and interviews performed with the lecturers at the So as the figure 1 suggests, all respondents agreed on the crucial role EI has in developing learners' ability to deal with their own and others' emotions, and to help them build their self-identity, integrate, and manage conflict. Whereas figure 2, it refers to the fact that 6 out of 7, that is 86% of respondents, agreed that EI should be introduced at level 4 and built up to level 6.
Usma, there's 1 more minute for you to present.
Okay. So these are my, responses gathered from both lecturers and the students. And here is the framework that has been used to embed EI strand in the health and social care curriculum at level 5. This basically specifically identifies an year-long module where in the module which is called Issues in Health, Illness and Society, the EI strand has been embedded, and it shows how it could be used, at level 5, and I have suggestions for both level 4 and 6 as well. So in conclusion, the purpose of the health and social care course redesign to embed an EI strand was to provide students with a comprehensive grounding on the topic of EI, both theoretically and conceptually. The focus was to help students improve their chances of success by adopting approaches to learning and teaching that will inform and prepare them for both their personal and professional future development and achievements. So the study concludes of embedding EI at all 3 levels of health and social care course, starting with the level 4 module, where learners obtain a basic understanding of the concept of EI and personal awareness, followed by an understanding of group dynamics and power play at level 5. Finally, at level 6, the framework proposes embedding EI in the context of leadership and management in order to provide learners with an understanding of EI in the context of their professional development and future progression. So both lecturers and students suggested some similar approaches to embedding EI within the health and social care curriculum. So a recommendation for future would be to introduce the topic from the outset and conduct EI inventories, tests or questionnaires in the first term for level 4, 5 and even top of level 6 students, followed by other modes of learning and teaching methods to comply with the learning outcomes as explained above. This should be followed up with a final test in the second term for level 6 students completing their degree courses and compared to their results at level 4 to provide them with tangible support on their development of EI skills. Note that EI inventories must be introduced cautiously, especially at level 4, keeping in mind the sensitivities of the students so that they do not feel disheartened if they score low at this, as this is not reflective of their possession or non-possession of EI competencies. So a key recommendation of the study is for the framework proposals to be presented to the course team for feedback and discussion on incorporating the proposal within the BSc Health and Social Care course curriculum.
Okay.
So the implications of this study are important for both students and lecturers, as learning EI may impact their relationships with each other and with their peers as well. This will encourage them to engage into a community of practice, whereby while learning and teaching, they will gather around the subject matter. This will help them engage with the world through the studied subject, through sharing experiences about scenarios for stimulating engagement. So the implications of successful embedding of EI within the Health and Social Care course curriculum are expected to be the rollout of the framework across other departments within School of Social Sciences and Professions, given the importance of EI within other departments highlighted by the study participants. This seems to be a probable outcome of the current proposal.
Okay, thank you very much, Uzma. I think, oh, sorry, you have one more slide. You really need 15 seconds.
No worries.
More than that.
Okay, thank you. It was just, to interact with the audience, and I just wanted to say that there are some, qualities as expressed by Daniel Goleman with regards to how we can recognize our own emotions and the emotions of others, actively listen to others, and actively participate in interpersonal communication and understand non-verbal cues of behaviors. And obviously control one's own thoughts and feelings. So these, how many of these of the above qualities that I have relate could they relate to themselves? So this is just a food for thought for them. Thank you very much.
Thank you, Uzma. I'm sorry to cut you short, but we really are running out of time. And our last speaker, Kevin Brazant, Brasnat. I'm pronouncing it actually. Brazant.
That's the
Kevin.
nice attempt though. I like it. But it's Brazant, yeah. Thank you.
Brazant is learning developer at the School of Social Sciences and Professions. And I assume, Kevin, do you have your, are you going to share your screen? Yes?
I'm going to share. I've got my slides. I can bring them up.
Okay, brilliant.
No, actually, I think
the floor is yours then.
Okay, thank you very much. Oh yes, and as always, WebLearn has totally messed up how my slides look, but that's fine. We'll work with it. Good afternoon, everyone. I'm Kevin Brazant. As Yolanda said, I'm academic mentor, learning development practitioner at the School of Social Professions, Social Sciences. What I want to do this afternoon really is just to have a chat with you all about a piece of work that I was engaged in since 2019. And it was an opportunistic project, which I did in collaboration with social work. And actually, as a result, it's kind of really taken off and developed. So I just wanted to kind of share my work from that. So in terms of framing the session, really, I'm calling this, learning from the lads, which stands for, the acronym is Looking After Dad Survey. And I'm going to be talking about problematizing father engagement as part of social work education. So in terms of giving you an overview and what I'm going to talk about, I'm just going to really, as part of this conference paper, share this opportunistic research project, which consisted of me working with the North East London Teaching Partnership, which consists of 5 North East London local authorities and 2 universities, which London Met is one and the other one is UEL. This project was delivered between 2019 and last year. And really, what I'm going to say in short with this paper is that the initial findings seem to suggest that there's a real need to revisit notions of masculinity and fatherhood as part of children and family workforce development. And I think there's something to be said about creating spaces to reimagine, reframe masculinity in partnership with both men, and using other theoretical concepts and ideas found in disciplines such as anthropology and critical masculinities to explore some of these themes. And basically, the conference paper recommends that we should problematize father engagement as part of social work practice education. I would argue that it extends to other areas like early years, you know, working with children, education more generally anyway, as well as health and social care subject areas as well. So in terms of positioning myself in terms of the research and my work and my practice, it's important for me to kind of reiterate, as you already know, I'm a learning development practitioner in the school. I support mainly social work students, youth work students, and community development and leadership students as well. And as part of this project as well, my role is extended to being involved in the Empowering London initiative, where I'm a challenge champ, and I sit on the crime strand as part of that initiative. And also as part of social work, I do the odd guest lecture around promoting positive father involvement and masculinities more generally. Beyond obviously my day-to-day life in the academy and in the university, I am a father. I'm also the founder of a coaching practice called Daddy CPR, which stands for Coaching Promotes Resilience. And this mainly involves the work that I do beyond the academy, mainly in a community setting, facilitating community forums and having conversations mainly around men's health, mental health and general well-being, as well as exploring themes of masculinity, fatherhood, and promoting resilience. And with that said, it's really important for you to get a sense of my kind of methodology or my approach to the way that I engage in my work, both in terms of research and as well as part of my general practice. And I'm a big fan of anthropology. I previously did my master's in applied anthropology and youth and community work some years ago. And I was really interested in the idea of participant observation and ethnographic study of people and being immersed in the field of research. And one particular aspect of that I was interested in was the autoethnography. And basically an autoethnography is an approach to research and writing that seeks to describe and systematically analyze, you know, personal experience in order to understand cultural experience. This approach challenges canonical ways of doing research and representing others and treats research as a political, socially just and socially conscious act. A researcher uses tenets of autobiography and ethnography to do and write autoethnography. And I just want to stress, I think some of the reflective assignments that we get our students to engage with is no short of an autoethnography, in my opinion. I think when we're asking students to reflect on their practice and to reflect on their learning and how it improves practice or helps them to develop their skills for when they become practitioners, I think it's very much aligned to this principle. And for me, this is where my project was situated with social work, because students were expected to do an evaluation of their learning to date. And I'm going to reveal how that went shortly, actually. And a key part of my work has been also outside to be involved in supervision practice. So I'm very interested in looking at how people develop their practice, mainly around engagement with men in local authorities, particularly around social work. And as part of that role, I do see that supervision practice does align very well with autoethnographic reflection, as well as personal reflections. And I've used creative approaches such as image-based dialogue to facilitate those conversations. And it's really powerful when you get people in a room to talk about their experiences and their practice as part of a group supervision context. And I think it's been great to bring this into London Met as well, whilst working with students to think about their practice. So just to quickly situate the bigger picture and the kind of my personal and professional commitment to why I do this work. Some of you may be already aware of this. Suicide is a big killer of men. Men are 3 times more likely to take their lives compared to women. This does seem to impact a certain group of men, a particular age group, largely between 45 to 49 years of age. And I think this is a real issue and a problem. And we know that from data suggests, some of the research that has come back from the ONS suggests that, you know, in general terms, the impact that's causing men to kind of do this is usually linked to things like relationship breakdown or family breakdown, or also men buckling under the pressure of the impact of toxic masculinity, or trying to appeal and meet these toxic ideals of what masculinity means as well. And when men don't seem to meet those ideals, this is where we have rupture and issues. So this is what has been a focus for me as part of my work. So in terms of the actual LAD survey itself, what I did was working with students in social work. I administered the LAD survey where, as part of the North East London Teaching Partnership, I basically was invited by the senior lecturers, Dolores Tracy, who I want to acknowledge and thanks for allowing me to participate in that project. She's no longer at the university, but it was her that suggested that I do this, where I sent out this survey amongst the 5 borough partnership. We had over 250 responses to the survey. And really, as part of the survey, I was just wondering how social work practitioners felt in terms of their confidence in responding to issues that men have. How confident were they to address these needs? And because the project or the survey was so popular, this also extended to the States as well, where we had the equivalents in Delaware in the States that are very interested in my survey and actually asked me to come along and present some of the findings from that as well. And I'm going to quickly whiz through what some of the responses from the survey was. So as I said, obviously, unfortunately, it's not been great to have had WebLearn do my slides, but it's cut off some of my quotes, but that's fine. But from it, social workers felt that it was quite difficult to engage with men or fathers who had previously had a negative impact or a negative experience of engaging with services. Some social workers actually reported that COVID was quite good for them in the sense that because of the lockdown, they found it much more easier to engage with fathers and men, where ordinarily they would have been at work. But because obviously we all was under lockdown culture and was isolating, it was encouraged that they were able to do video calls, Skype calls, web calls, which was very helpful for practitioners to kind of get a sense of what was happening with the fathers and the families that they were engaging with. This survey had such an impact that it then actually went on to inform a further training needs analysis for local authorities and resulted in me being invited to come out as part of the partnership to do seminars and focus groups with local authorities exploring this in a bit more detail. So when I then went out and did this further work in the local authorities, I was very keen to kind of develop on the survey, and I had a number of questions that I put to those social work practitioners. And basically, in essence, what I was asking them to do was to think about how inclusive their father practice was. And I had some key questions to ask them as part of that. I asked them to promote how well were they able to promote positive father involvement, and what was the challenges, what was the opportunities, and what was the implications for practice. And through that, we were getting them to think about what their current CPD training was like around dads, and supervision, and how much of this was brought up as part of their conversations in practice, and how effective was their current training in CPD in engaging with those fathers, and equally as a result of this, how confident were they in engaging dads overall, particularly for dads that may have been perpetrators of DV, domestic violence or abuse, or had been non-resident fathers or single dads or fathers in crisis. And as part of those seminars, I just wanted to show you some images from those sessions that I did actually. And these are some, obviously this was pre-COVID, so this was around 2019 when I first went out and I was doing the workshop. So I was getting social workers to creatively engage with these themes and topics, and they absolutely loved it. And it was a useful way of really breaking down some very difficult conversations around masculinity and looking at men generally, who are often framed as being risks or perpetrators of DV. So it was good to kind of get them to kind of look at men and fathers through a different lens. Some of the other activities that I did also, which you might want to consider doing right now, is I used a technique called image mediated dialogue, where I got them to consult images which I present to them around what best represented fatherhood or best represented images of masculinity. And that was also a useful way of kind of reframing the conversation, so people were able to kind of engage in it and then further have a dialogue around our wider views around masculinity and how men show up in society, really. And I've got further images here as well, and I used some of these images. You might recognize me from one of them there, where I spoke about what the best images were to represent fatherhood. And parallel to that, although I was doing this with the local authorities, what I was also doing with students at the university here at London Met as part of the undergrad and postgraduate programs was I was delivering similar sessions as part of their lectures. And what was really fascinating about this was the fact that students, the modules I delivered them in, and thanks to Hazel Cutts, senior lecturer in social work, for her communications and values module, where I was doing these sessions, students were expected to deliver or write up a reflective evaluation of their learning. What was really fascinating was across the full module, I only appeared once or twice on their modules, but my session had such a profound impact that most students actually wrote about the sessions that I did in relation to their practice. And as you can see, I'm just showing you some quotes that were lifted, or extracts that were lifted from the actual assignments that they wrote. And I'm very grateful and thankful to the students for allowing me to share, giving consent to share these extracts as well, as they found that it had quite a profound impact in terms of them preparing to go out on placement as part of their practice. The next one, which was quite interesting, was one of the students spoke about, during the academic year, having learned the importance of father involvement in assessments. And initially, due to their personal experience of having an absent father or role, they were a bit skeptical about the topic. And I found this was actually mirrored, this experience for students before they go out to practice. This was very much mirrored with existing practitioners out in the field. There were practitioners that were very against this topic and found it very difficult at times to sit with and to navigate and talk about. And what was really encouraging from doing this early with students, I think, was you were able to kind of demystify some of the myths sometimes around men, and also trying to allow time to really think about this in a more holistic way by having different perspectives in the way that we view men and look at masculinity. And just to build on that, this aligns obviously with wider research which was done by Ashley and Swan, who did research around breaking down barriers into how we kind of work with men and families, particularly around child protection and safeguarding. And this was a really key question that came up, which I think resonates with my own kind of anecdotal observations and primary research, which was we need to really think about how power and gender relations and personal experience, for example, of your own father or your partner, or having been a father yourself, may be shaping the perspective that you have and how it actually influences your practice. Something to stress here, obviously on the front line and doing this work, most practitioners are mainly women that are on the front line. If there are some of those women have had experiences of or challenges of domestic violence or survivors of DV, how much can that personal experience also impact you or influence the way you engage with men or perpetrators as a part of your practice or work? Yeah, so that's something else to kind of consider. Also, as part of the wider research context, when we consider this about looking at further barriers that impact on the engagement of public services or social workers with men, what research had told us by Maxwell et al. Back in 2012 was that there was often this culture within local authorities where men became labelled. There were good fathers versus bad fathers. And, fathers were labelled based on their reliability, trustworthiness, and their engagement with services. So, for example, if there were fathers who couldn't attend appointments because of work commitments, they were often deemed as bad fathers, or fathers that were difficult to engage. And there was very little appreciation for how much work plays a big part of a man's identity to some extent, you know. But also, in addition to that, when we look at traditional practices, when you look at the US, and I think there's very much synergy here in the UK, a US study revealed that, you know, it was assumed that the majority of the time mothers were the ones that were responsible for the care of the children. We know looking at fatherhood is a very recent conversation and development. We're aware that obviously for a very long time, it's only I think in the last maybe 15, 20 years or so, we've really considered thinking about fatherhood and thinking about shared care and changes in terms of family dynamics and blended families and all of that stuff. So it's been quite recent in us starting to think about this. And I think we're all playing catch up really as a society around how we respond to these needs. And as we know, this fits within the wider backdrop of the conversation of whether there is a crisis of masculinity. For me, I think it's a matter of perspective, and it depends on what lens you're looking at it through, to be brutally honest. Looking at this, I think a helpful model or a person to consult with to looking at masculinities is to consult Joseph Gelfer's work, who introduced this concept of 5 stages of masculinity. And Joseph Gelfer's work, I won't go into any great detail now because of time, but what I would encourage you to do if you are interested in this is to think about what stage are you at with regards to having conversations around masculinity. And both men and women can engage with this. However you identify, you can identify and contribute to this conversation. And he broke down these 5 stages. And he felt that the majority of people were at stage 1, where there was this sense of an unconscious masculinity. And this is where, you know, those are the people who don't even think about masculinity and not debated it, not even consider it, don't even discuss it as part of personal life or work. And actually, those people are the ones that are likely to be more influenced by the men in their lives, their uncles, their fathers, their brothers, in what it means to be a man around masculinity. But then when we move through the stages, when you get to stage 2 and 3, when you get these critical conscious masculinities, this is when we start to acknowledge that actually masculinity is a social construct. And we recognize that, you know, through a conscious masculinity, we need to recognize wider oppressions of patriarchy, you know, of hegemonic masculinities and how this impacts on women or men who are not white or heterosexual or identify as straight. Yeah, often you find there's a pecking order within that, and we know there's wider research by the work of Cornell, who did a lot of work around masculinities around this. But he felt that from his research, stage 5, which is the smallest number he felt people occupied in terms of that space in society, was that when you're beyond masculinities, it's acknowledging that actually masculinity is a social construct, and actually we shouldn't be guided by these constructs. We shouldn't be limited by it. And he even goes on to talk about multiple masculinities, and where he feels that we can sometimes at times adorn different masculine identities to fit in different contexts. So an example of this would be when you consider a corporate environment where it's dominated with men. Often women who are in a very male-dominated environment often take on very masculine traits to be able to survive in that space. So once again, this isn't just reserved to men or those who identify as being male. You know, at the end of the day, we can take on different masculinities and they can take on different shapes. And you may already be aware, but one of the key people who are at the core of this kind of conversation around this crisis of masculinity is the psychologist, the Canadian psychologist, Dr. Jordan Peterson. You know, whether you love him or hate him, he's often got that kind of Marmite effect for people, where he's very much been central to the conversation of where we're at in terms of masculinity. And sometimes his views can be very polarizing based on identity. So for me, I think, in a very, as you can hear the passion in my voice, I'm very passionate about having these conversations, and I think we should have them, especially being situated in the School of Social Professions and Social Sciences. We should be talking about this as part of our students getting ready to go out and become future psychologists, health practitioners, youth workers, social workers, educators. I think, you know, problematizing this notion of masculinity as part of education is a great way to have this dialogue and to explore it. And I think, you know, as we're moving towards an education for a social justice curriculum, it's more relevant now to kind of engage in that. So problem-based learning, I've just put up a slide which kind of gives you a sense of what that is as part of, you know, kind of education as a way of developing our practice as practitioners, as lecturers, as pedagogues. You know, PBL ultimately is student learning that is centered on solving a complex problem that usually does not have a single answer. And that's why I think I encourage us to go back and to consistently have a dialogue about this. I don't agree with a debate or dialectic discussion because it suggests there's an end in sight. I think a dialogue is more helpful to frame these conversations. And I'm very passionate as a result of, you know, the project that I've been involved in doing this at London Met, because this has led to students increasingly wanting to do this as part of their research projects. What I've seen is students has now gone on, particularly in social work as part of their master's and undergraduate program, to develop positive father involvement approaches. It's extended to them even asking me to come and deliver this session as part of their placements with their practice educators, because they feel that the culture of the organizations that they're working in could deal with further conversations around this. So this is developed into dissertation projects and further research projects. And I think it's important, as I've done as part of this talk, to really use this as a way, as I've done, to extract conversations, extract examples of students' work to see the impact that this has, not just personally, but professionally as part of your practice. And just to kind of finish up, just linking to the work that I do outside, I'm a part of a new forum that's been developed called Daddy's Voices. Really great forum that I'm a part of. I'm one of the speakers and the leads on the forum. And really the forum is about creating a safe and confidential space for fathers to come and meet with one another and to talk. The forum is really mainly targeting fathers that reside in the Lambeth and Southwark areas. However, they do have an online forum at the moment which is using Zoom, and this is extended to all that can attend. So there's no geographic limitations for those that want to engage in the forum if they wish to. But just the Lambeth and Southwark restrictions extends to the research project that they're developing, because the fathers are then going to become trained up to become community researchers, where they will then go out and then train up other fathers around their needs. And hopefully this can inform policy, inform practice, and yeah, make society that little bit better for living in, you know. So that brings me to the end of my presentation and talk, and thank you. I really enjoyed it. Thanks.
Thank you very much, Kevin. Fantastic presentation on masculinities and fatherhood, and all the ways that you are developing that research, also engaging students, as also the work of Usma have done in her presentation. I would like to say a big thank you to Professor Julie Hall, who is our new Pro Vice Chancellor for Academic Outcomes. Thank you very much for joining us today. It's great to have you here. And I would like to go through the chat now, but you can raise your hand if you'd like to ask any questions. please do. There were some issues in the chat, but so interesting. Okay, so a lot of congratulations from people for the presenters. Malonia Johnson says, very interesting, although this is a societal problem, I believe it's more prevalent among ethnic minorities. I suppose, Malonia, that was addressed to Kevin, if I got it right.
Hi, Yolanda. What was that question? Oh, sorry.
It's a comment. Yes, it's very interesting. Although this is a societal problem, I believe it's more prevalent amongst ethnic minorities.
I'd be interested to know what's more prevalent exactly amongst ethnic minorities, if you don't mind me to unpack that.
Yes,
a bit.
Malonia, if you can add a bit more, Malonia, that would be great. Verona say, I absolutely agree. More open discussions on masculinity, especially in professional practice in education and health and social care sectors.
Yeah, 100%. I agree. Yeah.
I suppose, Shabna, you would like to make a
comment?
comment?
I think I understand what Melonia was saying about prevalent in some category, well, some groups like ethnic minorities. So Kevin, thank you very much for your presentation. It's very insightful and very interesting, because I come across this when I do interpreting for Kafkas and also social work as well. I find that the dad in that sort of environment or situation, they actually withdraw, and because they've been on that DVIP program, I find a lot of the time I find a difficulty to actually interpret, because they have that withdrawal symptoms where they're not admitting, or they don't want to partake because they've been, there's a taboo and stigma because of the situation they're led up to. So it's good that you're actually doing this research, and it's, like you said, in recent years everybody is aware of it now, and there are lots of programs that the dads would have part in children's lives, as well as the mums as well, despite whatever has happened.
No, 100% Shatna, I couldn't agree more. Kafkas. We need to really I don't know, are we recording? But we need to restructure Kafkas, in my opinion. I think, based on the views that we have, it has a very narrow perception of men, particularly. And I think, Shatna, what you're also speaking to is that men, we often see when men are coming on the radar of Kafkas or social workers, let's be clear, it's often in very difficult circumstances, and it's usually around safeguarding children and families, which often views men as perpetrators and maybe women as victims. But men can also be victims, women can also be perpetrators. And I found through the work that I did through psychoeducational work, that's very complex. It shifts several times, and I think we just have to have a more nuanced look at the complexities around it, and to be a bit more open around how we view this topic. And I think education is the key for doing that. So thanks, Shatna.
Yeah, I agree, because within our community, especially the Bangladeshi community, I find, although before used to not be, in the community, it never used to be out in the community where there was violence taking place and families separating, but now it is, and it is widely known. But it's always the fathers who's actually on there, and they don't speak up. And sometimes, it's sad. I mean, I'm as a woman, when I can see the genuine character where they actually the ones, but they're not speaking up, and they're not saying how it's impacted them and mental well-being as well. So obviously that actually holds them back, and because of the stigma in the community as well, to speak up, to actually say, well, actually I've been through so much that whatever's happened, it's not just that other party that I've become a perpetrator. So yeah. Thank you.
Thanks.
Yeah, thank you, Shabna and Kevin, for that interaction. There's so many comments on the conference in general, but also issues. Malonia, it clarifies that she was referring to patriarchy. So I don't know if that makes sense.
Yeah. No.
Yeah.
Sorry. Go on. Was you going to say something, Yolanda? Sorry.
No, she clarified that she was referring to patriarchy when she mentioned
oh yes,
for instance, although this is a societal problem, I believe it's more prevalent about ethnic minorities.
Yeah.
Don't know if you want to comment on
most definitely. Yeah, no, definitely. And I think going back to Joseph Gelfer's model around the 5 stages of masculinity, I think that would be considered at stage 3. Where we criticize wider society and we look at the patriarchy, and 100% agree. However, when you look at stage 2 of masculinity, I don't know if you've heard, there's been an emergence of kind of men groups where men feel that they very much have no voice, or they feel ostracized or excluded from society because they don't feel they have power. And then in actual fact, they often feel oppressed themselves. And I think what's good about Joseph Gelfer's model is what it suggests is that we shouldn't look at this through black and white or either or. We should be looking at these narratives coexisting and understanding them and where they come from, if that makes sense. Yeah.
Yes. Yeah, it does make sense. I will leave Malonia, you have your hands up because we were answering her question. So if you want to clarify or add anything, please.
Yeah, I was just going to buttress what Kevin said, because sometimes the men feel helpless because let's not forget it's some historical problem, because their fathers as well and forefathers were not hands-on dads at home. So if they're trying to do something and they don't feel appreciated, they tend to let go, like, okay, I'm not going to do this anymore, I'm just going to leave it. So it's like a cycle which goes round and round and round. So it's good that the young dads now have actually seen this issue and they are actually addressing it to make a change. So it's like a behavioral change that is happening.
Yeah, definitely. There does seem to be a generational thing there, where I think the younger generation, younger men are really embracing more fluid ideas of masculinity and what it means to be a man and showing vulnerability. And I think with the advent of kind of like social media and having these online conversations like this Zoom forum that I was talking about, I think are great steps forward, which never existed before. You know, before your Facebooks and your Instagrams, where were men congregating other than at work or in the gym or at the pub if people drank or consumed alcohol? So yeah, definitely, totally agree. Yeah.
Jasmine, can you have your hands up? If you'd like to put your microphone, or maybe not. Verona?
Hi, yes.
Hi.
I agree with everything that Kevin has to say. I feel so passionate about this particular subject. I've worked with perpetrators, non-perpetrators, and I always try to have an objective view when I am working with men, fathers, young men. What I wanted to find out from yourself, Kevin, is there going to be any more of these forums, you know, for number one, professionals to get trained around, you know, the way of thinking about masculinity, and two, for fathers in the community? Are there going to be more talks or events on this issue?
No, thank you for that question, and thank you for your comments and feedback. So the short answer is yes. At the moment with London Met, I'm currently, as I mentioned earlier, as being a challenge champ, I'm working with London Met to look at how we can make maybe some of the conversations that I've had with you all today more widespread and more accessible. with other local authorities, maybe that might take on the shape of a seminar or an information session or further training. So that's already happening, and it's about looking at how we can scale that up. You made a really interesting point, which I agree with. I think training and looking to train others in how to do this as well and to facilitate these conversations, I think, are equally important. So that's something that I'm wanting to see develop. In terms of the daddies kind of forums that you're speaking to in the community, the difficult thing is there's very little investment when it comes to investing in working with men or fathers, unless it has a label of domestic violence perpetrator or, you know, involved in serious youth violence or gang activity. If it doesn't tick those boxes, government doesn't seem to be very interested, to be brutally honest. So what I'm doing at the moment, I'm talking with charitable organizations like Future Men and the Fatherhood Institute, who I'm also kind of associated with, to kind of look at how funding and resources can be pooled so we can be creative to put on events and forums a bit like the Daddies Forum. But it's very, the funding is few and far between, really difficult. Hope that answers your question.
Yeah, it does. Let's very quickly, I know we have to finish up, because I do know of a couple of groups run by fathers in a children's centre in Haringey. So I just wanted to, and it's not about gangs or anything like that. It's just, you know, what's going on for their children, and they talk about whatever they talk about in men's group. So I just wanted to know, is there any way that how I can find you or email you, maybe to let you know how to get in contact, maybe? And they're non-funded, by the way, as well.
Did you say they're not funded?
They're not funded. They've been run by I think Connected Community in Haringey.
Okay.
It's helping them to put everything together, and it's to one is an Eritrean fathers group.
And this is the point. There's not very little funding, or it's based on services or organizations offering their resources in kind. Do you get what I mean? There's no real ring fence funding for this, but yeah, totally. I'm up for a further conversation. Anyone that's interested in following up with me on this, I've just put my email address into the chat for you all, so you can get me via that if you want to.
Okay, thank you. Thank you very much, Kevin, and the audience as well. I think we need to wrap up now, as we are out of time today. First, I'd like to read out a message from Kelly Cooper, the Dean of the school. It's a reminder of our final year level 6 students. If you haven't already completed the NSS, the National Student Survey, please could you take a few moments to complete this. You will have received some emails about this, and have a lovely weekend all. Looking forward to seeing you soon. In case you didn't see that, it's just a reminder of the NSS. I would like to thank all our speakers today for the presentations. I think we had a great conference with great presentations and discussions as well. I enjoy particularly the discussions and all the, well, I assume the food for thought, and this is what these events are about. So great discussion there. The recordings, which you will also see in more detail, different aspects of the research, different comments, as Kevin was showing, and Uzma was also showing some findings and quotations, very rich information there. You will be able to see in YouTube. We have a channel within the Center for Primary Health and Social Care, and probably we will be circulating the presentations via WebLearn. I would like to thank also again everyone for your attendance today. You've been an excellent audience, very engaging, very interesting questions and comments, and sharing your own practice, which is brilliant. So thank you very much, and have a great rest of your day, everyone.